PhD with me, looking at cell surface markers, including CD45RA, which is present on naive cells, and also very late memory cells, CD27 and CD28 that are expressed early and then are downregulated. And we know that, indeed, the functional responses to antigens differ, with late memory cells producing chemokines like MYC1 beta, early memory cells producing IL-2. We know that alloreactive T cells are less differentiated, and herpes virus-specific T cells are more differentiated. So there's, within individual lineages of CD4 cells can be young or old, just like people can be young or old, and they may have different functions when they're young than they do when they are old. And indeed, these cells are likely to be even more complex as we learn more. This is from a review by Stephen Jameson that was published in Immunity a few years ago, suggesting that there are multiple different cells that vary on the basis of longevity and proliferation potential. So I think that just as we don't see small blue cells as being all lymphocytes that we recognize in the 60s that some were B cells and some were T cells, we now recognize that all the T cells that we all thought were alike are also quite different. And we may very well be able to understand how to target individual subsets, either pharmacologically or by manipulating a graft. And that is likely to I hope, influence the way that we practice transplantation. So why does this matter? So this is exophytic HSV infection. The slide is not projecting very well, but I thought that this was impetigo. I thought this was a streptococcal infection. This actually was growing out, and in fact, near the patient's ear, there was a growth that almost looked like a cauliflower growth. I had never seen HSV infection on an ear, and it looked like a mass, a solid mass. And it turned out to be resistant HSV infection. This patient also developed ataxia, meningitis, visual hallucinations, and we treated with initially ganciclovir and then later foscarnet with improvement of all of these symptoms. So this patient had an unrelated donor transplant, had hyperacute graft versus host disease, which meant that the graft versus host disease was seen before day 15 or before neutrophil engraftment. He was on high-dose steroids, and this occurred again within the first 2 months after transplant. So these infections are very rare. Probably everyone in this room has HSV. We may occasionally, when we're under stress or sleep deprived, might get a aphthous ulcer in our mouths, but we don't have cauliflower-like lesions coming out of our ears. So this is what happens when you have a profoundly immunodeficient individual with cell-mediated immune problems. So how does effective memory break down? So I showed you a painting earlier called The Persistence of Memory by Salvador Gali. This is a follow-up painting called The Disappearance of the Persistence of Memory. And fewer cells can be transferred to the host. So if we have a cord blood graft, we are often transferring fewer T cells, or the cells are pathogen naive. In a cord blood graft, the donor, of course, has not yet seen these viruses, so we're not transferring memory cells. The host can fail to regenerate T cells, or antigen-specific T cells are transferred to the recipient but become impaired, especially in the setting of graft versus host disease. So we, in different studies, studying immune recovery in transplant recipients, I'm a T cell immunologist and study functional immunology, found, for example, that most CMV reactivation happens not because of the lack of virus-specific T cells. We actually found in a paper that we published in Blood in 2002 that when we studied a large number of allogeneic transplant recipients and we looked at virus-specific T cells with assays that measure the cells with the T cell receptor that can actually recognize CMV, that most of the patients reactivating CMV had very high numbers of virus-specific T cells circulating. This was surprising to us because we thought that patients who were having reactivation would have fewer virus-specific T cells circulating. It turned out that the cells were much less functional on a cell-per-cell basis than cells would be in URI. So in assays that we did in the laboratory, if I took my own cells and took my CMV-specific cells, 70 to 80% of the cells upon stimulation would produce interferon gamma, TNF-alpha. Cells that were isolated from these transplant recipients, 20 to 25% of the cells were producing cytokine in the same assay. So the cells were there, they had the right T cell receptor, they were capable of recognizing CMV, but they were functionally impaired. And indeed, we found that patients who were on tacrolimus alone had relatively preserved functional responses, but that when they were on steroids in addition to tacrolimus, the functional responses became very impaired. So we thought that the effect of steroids would be to cause lympholysis and to cause lymphopenia and to reduce the number of virus-specific T cells. What we found was that patients on steroids had often as many or more virus-specific T cells than patients not on steroids, but that the cells were dysfunctional. Okay? So it's important to realize that you can have an absolute absence of cells. In HIV infection, for example, when we studied patients developing retinitis, we found that we could not detect CMV-specific CD4 cells, which makes sense because they were directly infected. But the cells can either fail to be there or they can become functionally impaired. Okay? So I'm not going to go over this because I'm sure Dr. Andriansky will talk about this. But obviously we have early on pre-engraftment bacterial infections. Later on, post-engraftment, we have impaired cellular immunity and risk of CMV, and then the risk of fungal infections. And then we have a late phase where viral reactivation and fungal reactivation is often associated with impaired cellular immunity, especially in patients with graft versus host disease. So we have in the 0 to day 30, we have increased risk of bacterial infections, typically day 30 to 100, increased risk of viral reactivations in most patients. And then later on, relatively low risk for some, for many patients, but for patients who are still on immunosuppression, the risk remains high, especially for Aspergillus and other pathogens. When I was a fellow, the aspergillosis used to occur early, in the first 30 days after transplantation. Now the peak time for aspergillosis is around day 80 to 100, and that's in patients with graft versus host disease. I rarely see now in a patient who is hospitalized during the primary hospital course unless it's been prolonged aspergillosis. Okay. So again, therapies by phase of immune recovery, pre-engraftment, antibacterial, antifungal, pneumocystis, and antiviral prophylaxis. Post-engraftment, we continue antiviral prophylaxis and pneumocystis prophylaxis, and we do CMV monitoring and use preemptive therapy. And then in the late phase, we do antiviral prophylaxis for 6 to 12 months. We stop pneumocystis prophylaxis typically at 6 months, and then we can relax our attention, except in the setting of graft versus host disease. Okay, then we have to continue to be very careful. So these are vaccinations, and this is from, I would say, an article that every transplant physician and nurse should read, at least have available. It's actually too thick to read, it's 90 pages. But these are guidelines, the consensus guidelines for preventing infectious complications. When you read these guidelines that are published in PBMT in 2009, you'll see a lot of differences of opinion because there's very little evidence basis for most of these things. So immunization patterns or whether people allow their patients to eat fresh fruits or vegetables or other things is quite variable, but you see, I think, an intelligent discussion of the issues around these points. So it used to be thought that we shouldn't immunize patients because patients were incapable of responding to immunization, that we should wait until at least 1 year to immunize patients. We now recognize that we should start immunizing early. It's true that some patients will not respond or some patients will respond inadequately, but it's better to start immunizing early and then immunize more than once, and that we shouldn't change that. There are very specific guidelines, for vaccination, and of course, one of the things that we don't give live viral vaccines until 24 months after transplant, and certainly not with active graft versus host disease or on immunosuppression. So, but again, I won't go over the details; it's too much for this talk. But you should review this, and we can talk about it. So, in cord blood transplantation, because I think in pediatrics and adults, I think that there's obviously the desire here to do increased number of cord blood transplants, which is obviously critical. So I'm going to spend the next part of the talk talking about what we have learned from systematic studies of immune recovery. So factors in delayed cord blood transplant immune recovery include the fact that we transfer few T cells with no donor-derived memory cells. We have very prolonged absolute lymphopenia, and we have a delay of thymopoiesis, especially in adults. Despite this, virus-specific memory cells are detectable in many patients even relatively early, and I'm going to show you the data for this. Lessons we've learned from CMV infection in general, and this is from multiple papers that we published in the lab in the past, that there may be blind spots in the immune response. So in HIV infection, for example, we found patients who had CD4 counts between 500 and 800 and yet had recurrent CMV retinitis, which is thought to be impossible. We think that CMV retinitis occurs usually below a CD4 count of 50 or 100. But we found patients who had relapsing CMV retinitis with very high CD4 counts. And we found that they had, just like a scotoma, a blind spot in their immune response where they had a persistent hole in their CMV-specific immunity. So virus-specific T cells, as I told you, may be present but not functional. And then donor and host factors may influence risk, and GVHD important risk factor. So these are known herpes viruses. I talked about CMV. Martin talked about HHV6 in the cord blood transplant setting yesterday. We also have the alpha herpes viruses, which include varicella zoster virus, which can obviously cause shingles, which occurs in up to 30% of autologous transplant recipients. HSV 1 and 2, which usually don't cause the infections and the problems that I saw in the other patient. And then Epstein-Barr virus and EBV. These viruses, unless some patients are profoundly immunocompromised or receive T-cell depleted transplants, are not very commonly an issue. And by doing EBV monitoring, we can usually stop the lymphoproliferative disease. You'll get quite a different perspective by talking to Dr. Castro from Memorial Sloan Kettering, because they routinely use T-cell depletion. So in T-cell depletion, they see post-transplant lymphoproliferative disease. Practicing at MD Anderson for nearly 10 years and at the University of Miami for 5 years, I have not personally had one of my own patients have post-transplant lymphoproliferative disease in 10 years. So the need to do EBV-specific immunotherapy is greater at Sloan Kettering because we routinely do T-cell depletion. So I would say the way we approach this is we do look when we have fevers or when we have other complications for EBV viral loads. If the EBV viral load comes up over 10,000 copies by quantitative PCR, we give rituximab. And doing that, you can virtually avoid post-transplant lymphoproliferative disease. So I don't really worry too much about these viruses, but these viruses cause problems early on. I won't go over this, but obviously there are multiple sites of CMV disease. It can indirectly cause graft rejection, immunosuppression, and increase the risk of fungal and bacterial infections, sometimes because drugs like anciclovir can also suppress the neutrophil counts. But it can clearly cause pneumonia, GI disease, hepatitis, and much more rarely retinitis. Retinitis occurs for reasons I don't understand still, commonly in HIV-infected patients, but uncommonly in transplant patients. So I have seen a few patients with retinitis in the transplant setting. So the strategies for CMV can include prophylaxis, which is easy. It covers direct and indirect effect, and monitoring is not required if you give prophylaxis to everybody. On the other hand, you can overtreat exposed individuals not at risk, that is, would not develop reactivation to the toxicity, including with ganciclovir neutropenia or Foscarnet nephrotoxicity, and it may delay immune reconstitution, and it's expensive. So if you look at CIBMTR centers around the world, about 25% use prophylaxis. In Australia and New Zealand, more than 50% of the centers use prophylaxis. In the US, less than 25% of the centers use prophylaxis. We use preemptive therapy. At the Anderson, they use preemptive therapy. Most people will start prophylaxis if they use it at engraftment. Very few do it pre-transplantation, prior to infusion of the graft. The length of treatment can be up to 3 months or 3 to 6 months. But again, the majority of centers use preemptive therapy. So the advantage of preemptive therapy is it targets patients, targets therapy to those at highest risk, minimizes overtreatment, minimizes toxicity, and can improve CMV-specific immune recovery. Disadvantage is it misses some cases of CMV disease that are not preceded. So sometimes you can get a rapid increase in viral load, and that can lead to pneumonia and even death. And it relies on the availability of sensitive CMV testing, so you have to be able to get real-time quantitative PCR. At MD Anderson, real-time quantitative PCR was done in-house, so we sent the sample by noon. We had, by the end of the business day, the CMV quantitative PCR results done in the same hospital. In Miami, we don't have same-day real-time quantitative PCR, but we've arranged to send it to a laboratory across the country, and by the end of the next business day, so if I send a sample by 5 p.m. on Monday, by Tuesday at 5 p.m., I have the result of that quantitative PCR and can decide what to do. I prefer same-day feedback, but there's a trade-off. I want that to be done with the highest efficiency, and so that can be done. But then you need to make sure that your lab gives you reliable results, and these are PCR-based assays that can have problems. So when we studied immune recovery, we found 60 to 70, and when we studied, we performed very large studies, 270 consecutive allogeneic transplant patients at MD Anderson. What we found was that the rate of reactivation in the first 100 days for CMV was 60 to 70%, but we also found beyond day 100 that 30% of patients reactivated CMV. Before we did this analysis, it was estimated that beyond day 100, less than 10% of patients developed CMV reactivation, when we found that it was 30%. So I'm going to show you the study that was published by Ebru Nozemir, who is a Turkish PMT fellow. Actually, is the director of the bone marrow transplant program and hematology program at Hacettepe University, which is a very old university in Turkey. Ever did a study, and we found that 54% of patients who had late reactivation had early reactivation, 31% had late reactivation, that is beyond day 100. Of the patients, 45% of individuals with early reactivation, that is before day 100, had late reactivation. 15% of the individuals with late reactivation had isolated late reactivation without any antecedent early reactivation. So you have to realize that CMV reactivation, when it occurs before day 100, that almost half of these patients will also reactivate beyond day 100. I know that we start to relax after day 100, so this is important to realize that they're not out of the woods. But some patients can actually develop late reactivation without ever having reactivation in the first 100 days. So again, you have to make sure you do this. So I'm going to show you some analyses we did to look at the risk factors for late reactivation. We found that lymphoid malignancy patients had a higher hazard ratio for the development of CMV reactivation. The lowest risk patients were patients who had a myeloid diagnosis, that is AML usually, and had both the donor and the recipient were CMV seropositive. Realize that if the recipient is CMV seropositive, but the donor is CMV seronegative, you're not transferring any virus-specific T cells to the recipient. So when the patient was positive, but the donor was negative, there was a higher likelihood of reactivating than in the same situation where the donor was positive. And in the myeloid patient, same was true. That the patient was positive and the donor was negative, that the risk of late reactivation was greater. Remember, these are events occurring beyond 3 months afterwards. So you would think by this point it shouldn't matter. But these transplant-related factors, host and donor-related factors, actually determine events that occur many months later on. Chronic graft-versus-host disease in multivariate analysis was also important. So patients with chronic graft-versus-host disease had a twofold risk of late reactivation. So in chronic graft-versus-host disease, in patients who had no early reactivation, there was a 20-fold risk. So when somebody does not have viral reactivation before day 100, and they develop chronic graft-versus-host disease, their risk of late reactivation is 20 times as high as the individual who has no chronic graft-versus-host disease. And to put this in perspective, so this is what's called a CART analysis, where we branch the risk factors. So individuals who have a early CMV reactivation are at higher risk if they have acute graft-versus-host disease, are at higher risk if they have lymphoid malignancy, and if they have a matched unrelated donor, matched related donor, they have a lower risk than unrelated donors or cord blood transfusion. The risk was higher than individuals who had no graft-versus-host disease. So again, graft-versus-host disease is an important factor, donor type is an important factor, and donor-recipient sero status are risk factors for late reactivation. So we developed a risk analysis, which was published in this paper. And the low-risk patients were patients who had no early reactivation, who had a matched related donor, no acute graft-versus-host disease, and myeloid diagnosis. These patients had only a 15% risk of late reactivation. Still not zero. Okay, 1 in 6 will still reactivate. But patients who had a matched unrelated donor or a mismatched donor or had graft-versus-host disease were in a very high risk. 65% of those patients developed late reactivation. So, you have to, I think, develop your own. I wouldn't worry about any one formula, but you have to think about the factors that determine risk. So when you get called by that emergency room physician, those things that I asked, does the patient have graft-versus-host disease? Do you know if they have prior reactivation? These are the things that should go through your head and make you decide how you should react and whether you should react quickly, or maybe you can tell the patient, don't worry about it, see me in 2 days when you have your next appointment. Okay, it's not unusual that patients who die due to CMV pneumonia are actually being taken care of by their local physicians and are doing well. And they go to their doctors, they have fever, they say it's a viral infection, they get a chest x-ray, they see a pneumonia, and they get treated for bacterial pneumonitis, and no one even thinks about CMV. They come to your hospital by air ambulance or by ambulance, they're on a ventilator, you do a bronchoscopy, and you find out that this was CMV that was untreated for a week, and that patient has a high risk of mortality. So I think you have to educate your local doctors also. Ideally they have access to CMV testing, or you can find a way to get that testing done at your institution. And those are things that are important, I think. CMV can be, if it's detected in the first several days, can really be managed. If it's allowed to go to very high viral load and to develop end organ disease, then you can really be in trouble. Okay, so again, patients with match-related donors and no graft-versus-host disease are at lower risk. Patients who have unrelated transplants or have had a history of graft-versus-host disease are at much higher risk. So this is from a nice review, I won't go through it, but by Michael Boak at Seattle and Per Lundman and the Karolinska, which shows you that there is differences of opinion in how to initiate therapy. So this is a nice article called How We Treat CMV in Transplant Recipients. The bottom line is that with higher immunosuppression or shorter doubling times, the risks are higher. At the Karolinska, they use the same threshold for all patients, 1,000 copies. At Seattle, in cord blood transplant recipients, they treat CMV reactivation at any level of viral reactivation. But in allotransplant recipients who are after day 100, they use a more relaxed threshold. Okay? So I think, again, you can develop your own approach to this, but I think the important thing to understand are the principles and what factors govern immune recovery. So the treatment of CMV disease, if it occurs, this is not now prevention, is ganciclovir, 5 milligrams per kilogram twice a day. The side effects include neutropenia. Second-line therapy includes foscarnet, 90 milligrams per kilogram twice daily. And again, this is associated with nephrotoxicity, electrolyte abnormalities, and sometimes risk of seizures. Third-line therapy, we don't like to use cidofovir and other agents that can be used if you have resistant infections, can include cidofovir. Therapy for disease is typically given for at least 2 to 3 weeks, followed by a minimum of 2 weeks maintenance. In some places, that maintenance continues for up to 6 weeks or sometimes to day 100. They're quite variable practices. But I think at very minimum, if you have known CMV disease, you should treat for 2 weeks and do maintenance therapy for at least 2 more weeks. So I'm going to move more quickly. I'm going to talk about cord blood transplantation. This is causes of death in cord blood transplantation from Duke. This is Paul Sebulch, who's a pediatric collaborator, and with Joanne Pritzberg did many of the cord blood transplants at Duke. 50% of their deaths were due to infection, with the other deaths occurring due to relapse or other things. When we studied patients who got double cord blood transplants in adults, we found that CD3 T cell numbers were very low. In this study, we were the first to show that you can get engraftment from both cords in monocytes, B cells, and NK cell subsets, but we found, as often the case, profound lymphopenia in the CD3 T cell compartment. So one of the critical things that I want to show you, this is data that were published in 2007 in Blood, but are being updated. Actually, we're going to submit this to the ASBMT meetings. We found profound CD4 and CD8 lymphopenia. B cell and NK cell levels, these are adult cord blood transplant recipients, actually recovered to normal levels by day 60 after transplant. But very significantly, when we looked at the function of the thymus, which I told you does function in all of us to varying degrees, when we studied other allogeneic transplant recipients, and these are samples drawn from patients between day 20 and day 100, 80% of the time we find evidence that the thymus is producing new T cells. When we study healthy donors, almost all healthy donors will have evidence of thymopoiesis. But when we studied adult cord blood transplant recipients, we found that very few of them have any early thymopoiesis in the first 3 months after transplant. So this is contributing to a failure of regeneration of T cells after transplant. When we looked at the functional immune responses, these are responses that are polyclonal responses stimulated by superengine, staph enterotoxin B, or CMV. We did find functional responses, but they were lower than what we saw in other allogeneic transplant recipients. So special considerations for patients with chronic graft-versus-host disease. We continue prophylaxis for pneumocystis. We continue to monitor CMV and EBV reactivation because of what I showed you earlier, that if we don't do that, we're going to miss reactivation. We maintain bacterial prophylaxis for encapsulated organisms with penicillin or azithromycin or sometimes with fluoroquinolone. We consider prophylaxis for HSV or VZV with acyclovir. We consider antifungal prophylaxis. If patients are on steroids more than 0.5 milligrams per kilogram per day, I keep them on posaconazole, which is a broad antifungal agent with aspergillus activity. And I maintain a very high degree of vigilance, especially for patients on moderate to high doses. So when a patient is below 0.5 milligrams per kilogram, when their steroids are being tapered, I relax a little bit, but when they're on this level or above, every small sign of infection I take very, very seriously. So this is from, again, that Tomlin article, and I'm almost done. I have 2 slides left. Okay, so I think I'll go down on time here. The type of transplant, it's a higher risk with allogeneic transplant, lower risk with autologous or syngeneic transplants. It depends on graft manipulation, much higher risk of infections with T-cell depletion. Time from transplant, lower risk with more time. Pre-transplant factors, if extensive immunosuppressive therapy, like fludarabine in lymphoma patients or prolonged neutropenia, or if they come into transplant with an infection, this increases the risk. Obviously, GVHD, increasing mismatches I've shown you before, immunosuppression, especially with corticosteroids, ATG, or campath or drugs given after transplant. So these are, I think, general principles. Okay? They're not exactly a specific roadmap, but I think it's very important that everybody, from the nurses to other physicians to the emergency room doctors, all understand the general factors, and they know how to look at two patients who may be at the same point post-transplant and say, this patient is at very, very high risk. Okay, so the key principles. It's important to understand the host and the graft factors that govern the infection risk, age, serostatus, graft type, or conditioning. Graft versus host disease requires special consideration and prompt attention when infection is present, is suspected. And finally, it's essential that patients, in addition to healthcare workers, understand their own risk of infections. We're very careful to make sure that healthcare workers are immunized against influenza, that when they have a cough, that they cover their cough, or ideally don't have patient contact at all. It's impossible to avoid this completely. But it's important to maintain not only an understanding among physicians, but a culture of infection control and care. So final thoughts, how do we reduce GVHD incidence without impairing good T cells? How do we improve immune reconstitution? I think we have to continue to improve outcomes in alternative donor transplantation, including cord blood transplantation and haploidentical transplantation, and ideally develop targeted interventions, which include pharmacologic interventions or immunologic interventions that are cancer-specific to maintain remissions while donor immunity and graft versus leukemia responses take hold. So I'll stop there. This is, you have a beautiful ocean here, but this is a beautiful Miami beach. And the last part of the slides, again, for those of you, again, Dr. Flores has provided CDs for individuals here, contains some slides. And again, there are, in this article, which is, again, published and easily available, there are a lot of specific guidelines for bacterial infections, how to manage herpes simplex infection. There's a lot of fuzziness because people do this quite differently at individual institutions, how to manage varicella zoster, who are the risks at standard or high risk for fungal infections, and patients who are at high risk for molds. So rather than, I think, saying you should do things in a specific way, I think look at these guidelines, look at how other centers do it. You're always welcome to email us and say, what would you do in this patient? I certainly never think that I know enough, and I'm often emailing other individuals and saying, what would you do with this myeloma patient, or how would you manage this complex situation? And we're happy to help in that way. Okay. So again, you assist us. All these recommendations are here. Happy to take questions. But,
¿Alguna pregunta para el doctor?
¿Qué en español? Ahora que estamos con el corte aquí, what about the section about machine H1, N1 in patients post-transplantation?
Yeah, so
necessary or no?
So we had 2 weeks ago in Miami, we had a death of one of our patients to H1N1 influenza. So it is important.